Obesity. WHO define obesity as condition with excess body fat to the extent that health and well-being are adversely affected. It includes presence of excessive body weight for patients' age, gender and height. Following terms can be used to describe this concept: total body weight, TBW, actual body weight of patient, ideal body weight, IBW. Weight associated with lowest mortality rate for a given height and gender, and be calculated by Broca's index. IBW, kg, equals height in cm, x, where x is 100 for adult males and 105 for adult females. Predicted body weight, PBW, males, PBW, kg, equals 50 plus 0.91 x, height in cm minus 152.4 or 50 kilograms. Male, 5 feet, for every 1 centimeters increase add 2.3 kilograms. Females, PBW, kg, equals 45.5 plus 0.91 x, height in cm minus 152.4 or 45 kilograms. Female, 5 feet, for every 1 centimeters increase add 2.3 kilograms. Lean body weight, LBW. It is the total body weight minus adipose tissue. Approximate 80% and 75% of TBW for males and females respectively. Body mass index, BMI, Quetelet's index, estimate degree of obesity. BMI equals weight in kilograms, height in meter. 2. Adjusted body weight, ABW, IBW plus 40% of excessive weight, TBW. IBW, tricep SKN fold thickness test. According to this, obesity is defined as value of 23 mm in males or 30 mm in females. Obesity classification. BMI obesity class. Risk of systemic diseases. Risk according to waist circumference, 19.9 underweight males, 40 inches males, 40 inches. 20 to 24.9 normal females, 35 inches females, 35 inches. 25 to 29.9 overweight, 30 to 39.9 obese. Average high, 40 to 49.9 morbidly obese. High, very high. 50 to 59.9 super obese, very high, 60 to 69.9 super obese, extremely high, 70 hyper obese. Anatomic distribution of body fat, central android cushingoid apple shaped obesity, peripheral gynecoid gluteal pear shaped obesity. Upper body distribution of adipose tissue, lower body distribution of adipose tissue. Increase oxygen consumption, decrease oxygen consumption. Increase incidence of cardiovascular disease, decrease incidence of cardiovascular disease. Body circumference indices such as waist circumference, waist to height ratio, waist to hip ratio. These indices helps to classify the pattern of obesity and correlate with mortality and risk for developing obesity related diseases. Obesity itself is associated with many diseases: type 2 diabetes, mellitus, hypertension, IHD, heart failure, coronary artery disease, obstructive sleep apnea, degenerative joint disease, cholelithiasis, GERD, thromboembolic disease. Management of obesity, medical, surgical. Indication for pharmacological treatment include BMI 30 kgm2 or BMI between 27 and 29.9 kgm2 in conjunction with an obesity-related medical complication. Bariatric surgery is currently the most effective treatment for morbid obese patients with BMI 40 kgm2 or BMI 35 kgm2 and those patients with obesity-related comorbidities not controlled with medical therapy are eligible. Lifestyle modification surgical options: balloon insertion, gastric ligation, banding, jejunostomy, gastric bypass surgery, sleeve gastrectomy. Medications: decrease energy intake, increase energy utilization, decrease absorption of nutrients. Example: phentermine, orlistat. Phentermine, sympathomimetic drug, decrease appetite. Side effects: SANS effects, dependence, abuse and withdrawal symptoms. Orlistat blocks absorption of dietary fat by inhibiting lipases and GIT. Improves blood pressure, FBS and lipid profile. Side effects: oily spotting, liquid stools, fecal urgency, flatulence, abdominal cramping and fat-soluble vitamin deficiency. Physiological changes in obesity: Respiratory chest wall compliance lung compliance work of breathing FRC worsened by anesthesia and supine position, VC, TLC, RVNCC unchanged metabolic activity, AV, MVOSA hypoxemia, hypercapnia. Pulmonary hypertension, systemic vasoconstriction, secondary polycythemia obesity hypoventilation syndrome Pickwickian syndrome difficult laryngoscopy anesthetist might face difficulty in bag mask ventilation. Difficult intubation in this patient will desaturate quickly, therefore must be pre-oxygenated cardiovascular total blood volume renal and splanchnic blood flow CO, 20-30 ml/kg of excessive body fat. Because of ventricular dilation and SV55 wall stress hypertrophy. Compliance and impairment of 55 diastolic dysfunction with LVEDP and pulmonary edema eventually systolic dysfunction obesity cardiomyopathy and B ventricular failure acceleration of atherosclerosis cardiac dysrhythmias ECG. Finding, low QRS voltage, 55 hypertrophy, left atrial enlargement, T-wave flattening in inferior and lateral leads, leftward shift of P-wave, QRS complex and T-wave axes. Lengthening of QT interval and prolongation of QT interval HTN concentric hypertrophy of ventricle in normal weight individuals but in obese it causes eccentric dilation sans insulin resistance, dyslipidemia. Hypertension hypercoagulability difficult venous access gastrointestinal gastric volume and acidity, delayed gastric emptying altered drug metabolism intragastric pressure GERD. Risk of aspiration severe pneumonitis risk of hiatus hernia fatty infiltration of liver, non-alcoholic steatohepatitis. Focal necrosis and cirrhosis abnormal LFTs renal and endocrine prevalence of type 2 DM due to resistance of peripheral adipose tissue to insulin abnormal glucose tolerance test risk of wound infection and MI subclinical. Hypothyroidism renal blood flow and GFR nephron function, natriuresis and further in arterial pressure morphological positioning transferring monitoring pharmacological principles. Total body water total body fat lean body mass altered protein binding blood volume cardiac output blood concentration of free fatty acids, TGs, cholesterol. Alpha-1 glycoprotein renal clearance unaffected hepatic clearance lipophilicity of drug organomegaly for most anesthetic agents dosing to total body weight is rarely appropriate, and increase the risk of relative overdose. Most anesthetic agents are dosed to affect e.g., loss of eyelash reflex, nerve stimulator response, relief of pain lipophilic drug hydrophilic drugs, barbiturates. Benzodiazepine large volume of distribution dose should be increased neuromuscular blocking drug distributed in central compartment lean body weight is used for dosing since volume of distribution is increased resulting in reduced elimination leading to prolonged effect slow emergence from fat-soluble volatile agent may be due to central sensitivity as much as due to delayed release from adipose stores perioperative assessment, history. 1. Comorbid, DM, systemic pulmonary hypertension, OSAOS, metabolic syndrome, IHD2. Met functional classification 3. Previous venous thromboembolism vena cava filter 4. Drug history 5. Previous surgery anesthesia 6. Stop and questionnaire 7. CPAP use at home 8. Inquire about history of obstructive sleep apnea, including snoring, daytime hypersomnolence. Partner may give history of apneic episodes investigations, ECG, RVH, TUL-R waves, right axis deviation, RV strain CXR. Underlying disease and prominent pulmonary arteries echo CPET, ABGS, POW2, PCO2 PFTs spirometry sugar charting LFTs IDL for difficult airway examination, vitals, NIBP, SpO2, signs of cardiac failure, JVP. Pathologic heart sounds pulmonary crackles hepatomegaly peripheral edema anatomical predictor of potential difficult airway. Limited movement of atlantoaxial joint and cervical spine by upper thoracic and low cervical fat pads excessive tissue fold in mouth and pharynx mouth opening mandibular movement nostril patency theromental distance short thick. Neck thick submental fat pad suprasternal, presternal and posterior cervical large breast in female's neck circumference, 40 cm, 17 inches single best predictor of difficult intubation in morbidly obese patients plan. 1. Perioperative thromboprophylaxis 2. Antibiotic prophylaxis 3. Anxiolytics 4. Prophylaxis against aspiration pneumonitis, H2 receptor antagonist, non-particulate antacids, PPI intraoperative consideration, equipment, specially designed tables with more weight-bearing capacity proper size BP cuffs. If cuff too small BP falsely elevated consider IABP positioning avoid head down positioning head up position proved longest safe apnea period during induction protect pressure areas to avoid pressure sores. Neural injuries and rhabdomyolysis ramped position tragus of urine level with sternum and arms away from chest. Towels folded blankets under the shoulder and head can compensated for exaggerated flexed position of posterior cervical fat airway adequate oxygenation and head-up position preoperative use of NIPPV or application of PEEP during induction will also combat with pre-induction hypoxemia anticipated difficult intubation. Awake intubation using topical regional anesthesia and fiber optic devices prudent approach to maintain spontaneous ventilation adjunct intubating tools and related equipment on standby, intubating stylets, video laryngoscopes, LMA and fiber optic bronchoscopes General anesthesia inadequate peripheral access CVC may be required tracheal intubation with controlled ventilation is the airway management technique of choice RSI preferred in obese if challenging airway or for patients with high risk of induction hypoxemia aspiration use of nitrous oxide is limited by high oxygen demand in this patient population short-acting opioids and dexmedetomidine preferred antiemetic should not be forgotten multimodal analgesia should be given moderate PEEP particularly after recruitment maneuver, most efficient ventilator technique to prevent postoperative atelectasis patient extubated and semi-recumbent, head up at 45 degree. Extubate once fully awake supplemental oxygen delivered after extubation regional anesthesia where possible regional anesthesia is preferred to general anesthesia high risk of failure of regional techniques in obese. If sedation required during regional TIN-seek it should be kept to minimum extra long spinal epidural needles should be available. Ultrasound may be useful epidural local anesthetic dose requirements are reduced as volume of epidural space is reduced post. Operative all obese patients should be observed until unstimulated for signs of hypoventilation specifically for episodes of apnea hyponia with associated oxygen desaturation early ambulation and VTE prophylaxis 45 degree modified. Sitting position will improve ventilation and oxygenation PCA morphine along with combination of paracetamol and NSAID watch for signs of rhabdomyolysis HDU care may be required with CPAP obstructive sleep apnea. Repeated episodes of complete airway obstruction leading to apnea, absence of airflow for 10 seconds. Or partial airway obstruction leading to hyponia both causing fall in oxygen saturation, 4% drop from baseline. It can also be defined as periodic partial or complete obstruction of upper airway during sleep. It is more likely to result from airway obstruction produced by excess soft tissue. Physiological abnormalities resulting from OSA include CVS hypertension, right heart failure, ischemic heart disease, cerebrovascular disease. Respiratory pulmonary hypertension, hypoxemia, hypercapnia, secondary polycythemia, endocrine reduced growth hormone and testosterone levels, diabetic instability, CNS impaired cognition, accident risk, anxiety, depression, chronic headache, GERD, cholelithiasis, others, embolic disease. Apnea is cessation of airflow, 10 seconds. Sleep disordered breathing encompass obstructive and central sleep apnea. Obstructive sleep apnea is present when there is persistent effort without airflow. Complete cessation of airflow, 10 seconds, despite continued ventilation, 4, 5, 10 times hour associated with decrease in SpO2, 4% from baseline. Obstructive sleep hyponia, cessation of 50% airflow for 10 seconds. 4, 15 times hour associated with decrease in SpO2. 4% from baseline OSA syndrome consist of OSA accompanied by daytime symptoms such as hypersomnolence symptoms. Restless unrefreshing sleep. Partner witnessed apneic episodes, nocturnal sweating, morning headaches, nocturia, reduced libido. Pathophysiological changes during episode of apnea. Hyponia during sleep. Narrow floppy airway in patients with OSA collapses as a result of decrease in dilator muscle activity and subatmospheric pressure generated during inspiration. Depending whether the collapse is partial or complete, snoring or apnea will result. Arousal is caused by decreasing PO2, increasing PaCO2 and increased respiratory efforts. Arousal response is accompanied by abrupt increase in BP and heart rate. Risk assessment for OSA. Stop-in questionnaire. Berlin Questionnaire ASA Guidelines. Risk factors for OSA: excessive weight, narrow airway, hypertension, chronic nasal congestion, smoking, diabetes, male gender, asthma, family history, acromegaly, Cushing disease, alcohol, sedatives, analgesics, neuromuscular disorders. Stop-in questionnaire. S. Snoring score. T. Tiredness. LOW. Risk. 3. O. Observed apnea, intermediate risk. 3-4, P. Pressure, BP, high risk. 5-8, B. BMI, 35 kg. 2 Note, 6 Require polysomnography. A. Age, 50, N. Neck circumference, 40 cm. 17 inches. G. Male gender. Berlin Questionnaire. Tiredness and fatigue after sleep, falling asleep while driving, presence of high blood pressure. Diagnosis of OSA. Overnight polysomnography. Gold standard data divided into epochs of 30 seconds. Apnea, hyponia index, respiratory disturbance index, oxygen desaturation index. Parameters to observed in polysomnography: heart rate, blood pressure, pulse oximetry, SpO2, airflow at nose, respiratory rate, electromyogram, electroencephalogram, electroaculogram, body position. Apnea, hyponia index, respiratory disturbance index. Defined as number apnea hyponia per hour of sleep. Classify severity of OSA syndrome together with degree of associated symptoms and hypoxemia: mild, 5-15 moderate, 15-30 severe. 30 treatment modalities for OSA: mild cases, moderate cases, severe cases. Weight loss as mentioned for mild cases by PAP followed by CPAP. Once control of respiratory failure is achieved, smoking cessation, nasal CPAP, alcohol and sedative intake reduction. Mandibular repositioning. Role of surgery in OSA: tongue base reduction or uvulopalatopharyngoplasty. Evidence is lacking regarding its significance when OSA is due to tonsillar or adenoid hypertrophy or tumors of larynx or pharynx. Surgical treatment is clear. Life-threatening OSA: tracheostomy. Perioperative management in OSA patient. Preoperative assessment: severity and complication of apnea, causes of OSA, mode of treatment and compliance, anesthetic management, impact of surgery on OSA, requirement of post-operative analgesia. Preoperatively, if patient is using CPAP, it should be continued till theater. Intraoperatively, a regional technique will circumvent the issue of airway management and suppression of arousal responses if GA considered. Then bear in mind regarding anticipated difficult face mask ventilation and difficult intubation. And use of opioids will depend on risk versus benefit. Postoperative HDU care with nursing and CPAP application. Obesity, hypoventilation syndrome, Pickwickian syndrome, result from long-term OSA. Triad of obesity, BMI, 35 kg. 2. Sleep, disordered breathing, OSA, and daytime hypercapnia. PaCO2 is greater than 6 kPa. All this ultimately leads to pulmonary hypertension and cor pulmonale. Other characteristics include: 1. Daytime hypersomnolence. 2. Hypercapnia. 3. Hypoxemia. 4. Polycythemia. 5. Eventually right ventricular failure occurs. These patients are sensitive to respiratory depressant effects of general anesthetics. Metabolic syndrome. Syndrome X. Insulin resistance syndrome. Cluster of metabolic abnormalities associated with an increased risk of diabetes and cardiovascular events. 5-fold increased risk of developing type 2 DM and 2-fold risk of dying from MI stroke. If 3 out 5 conditions exist, patient can be diagnosed as metabolic syndrome. 1. Central obesity. Waist circumference, 40 inches in males and 35 inches in females. 2. Dyslipidemia, TGs, 150 mg/dl. 3. Dyslipidemia HDL 40 mg/dl in males and 50 mg/dl in females. 4. Hypertension 130/85 mmHg or use of antihypertensive. 5. Elevated fasting blood glucose 100 mg/dl or use of medication for hyperglycemia.